Good afternoon. I'm Karen Holmes Ward. Welcome to CityLine. Today, our conversation with Boston's Public Health Commissioner, Dr. Bisola Ojikutu, will cover a wide range of topics that impact the city's diverse community. One of the top issues this summer, health equity.
Our health equity agenda is designed to take these gaps on directly.
The city is putting a new plan in action and investing heavily in addressing the most pressing needs and disparities facing its residents. Poverty, violence, and systemic racism all play into the wide range of health inequities in Boston and beyond.
There are differences by population in access to education and access to health care and access to insurance and access to the educational tools that you need to be able to use all of those resources. Those are what are driving many of the disparities that we see today.
Boston is a majority-minority city, yet continues to be listed as one of the most racially segregated cities in the country. In 2020, the City Council declared racism a public health crisis. Health outcomes for Blacks and Latinos compared to whites are persistent for many health indicators, from maternal health to chronic conditions like diabetes, asthma, and hypertension. And joining me now in the studio is Dr. Bisola Ojikutu. She's Boston's Commissioner of Public Health and the Executive Director of the Boston Public Health Commission. Welcome. How are you today? Glad that you're here.
Thank you so much for having me.
Earlier this month, the city announced its new long-term health equity agenda. Last year's report on mortality and life expectancy found some stark but continuing differences in average life expectancy among neighborhoods. So what are the factors that account for that discrepancy?
Well, first of all, I would say that Boston is a thriving and vibrant city, so much diversity, a wonderful place to live and grow. I think that the challenges that we face, though, are ones that we need to address aggressively, and that's why we've developed this agenda, Live Long and Well. So what we're seeing in the data, we have clear inequities, clear differences in life expectancy. There are parts of the city where life expectancy is much lower than we would expect. So parts of Roxbury, life expectancy is around 69 years of age. Parts of Back Bay, 92 years of age. So that's a 23-year life expectancy difference. It's not just Roxbury and Back Bay, though. It's other parts of the city, too. We have pockets of relative disadvantage where we need to do the work, invest, and understand what's going on so that we can improve.
This is not new information. No. What's going on? What's being done? What's the first priority to change these numbers?
So the issue here is that oftentimes when we look at health inequities, we tend to laser focus on the healthcare system, what happens within the walls of clinics and hospitals. And the reality is that much of what is occurring is outside of those walls. Health inequities actually begin within communities. We're talking about the drivers of poor health, social determinants of health, economic inequities. We're talking about wealth gap. We're talking about poor housing. We're talking about educational resources. We're talking about challenges that people face that are deeply embedded. Structural racism that's been going on for decades, longer than decades. So these issues are hard to tackle, and sometimes they're hard to talk about. So it's when we do that work, when we do that tough work, that we hope to get to some changes. So in this agenda, we're actually starting out, we're looking at cardiometabolic disease. Now that's diabetes, hypertension, heart disease, all things that we know do cause premature mortality, particularly amongst Black individuals. But what we're doing is we're focusing more upstream, so to those social determinants of health, thinking about economic mobility. What are the economic mobility drivers of the problems downstream, like poor cardiometabolic health? So somebody who doesn't have access to money, has a lower socioeconomic status, that's going to put them at risk. It's going to give them chronic stressors. And those chronic stressors are going to lead them to be overweight. It's going to lead them to have lower levels of physical activity. It may lead them to smoke. It may make it harder for them to see their doctor in the first place because they can't afford co-pays. You know, they cannot necessarily afford all of their medication. So these are the problems that we have to work on here in Boston, and it's tough work.
So how do you, what's the plan to close the gap, to take this wider approach?
So it's about partnership and collaboration. Okay, that's number one, as well as community engagement. So our first initiative is a partnership between Boston City, Boston Public Health Commission, the Atrius Health Equity Foundation, which is granting $10 million for us to invest, particularly in economic mobility, particularly in the issues to decrease that chronic stress that people face, and then to look at those outcomes, the cardiometabolic outcomes that I described. We're also working with our Boston Community Health Collaborative, which is the group of individuals who have been brought together to really focus in on what the community needs. So they do the community needs assessment on a regular basis and come up with a community health improvement plan. So that's the first step. We have many more steps in the process. We also need to look at preventable cancers, and we also need to look at drug overdoses.
Okay, speaking of drug overdoses, let's transition to this. According to the most recent data, opiate-related overdose death increased in Boston, but fell statewide. In fact, it was the largest single-year drop in over a decade. So why are Boston's numbers going up when the rest of the state is seeing significant improvement?
So Boston is a large metro area where we have services, and we take a public health approach to much of what's happening in terms of drug use, in terms of drug overdoses, in terms of people living with substance use disorder. I think you have to think about what that means in terms of bringing new people into the city and people who are looking for help, and we don't discourage that. We want to help everyone who we can. I think the other piece of this is that one of the epicenters of the drug use crisis is Mass and Cass, and it's still Mass and Cass, even though people from the encampment have been moved into low threshold safer spaces, it is still an epicenter. So these are the factors that are challenging us as we try to address this issue.
Let me share some more statistics. Among Black residents, the opiate mortality rate jumped more than 27%, and for Latino residents, nearly 16%. But the opiate crisis, of course, as you've just said, impacts all communities, regardless of race and income. Yeah.
So,
why numbers higher for people of color?
Well, I think that's a complicated issue. What we do is when we think about this, we try to think, so what are the immediate causes versus the root causes? So immediate causes, what we're seeing if we look very closely at the numbers, is most of these deaths amongst Black individuals particularly are a combination of cocaine and fentanyl. And so what we're seeing is that either unintentionally or intentionally, people, are using those two drugs together, and they are dying from overdoses. And I think what that's saying to us is that maybe we are not addressing this as broadly as we should. We're spending a lot of time just talking about opioids, and we're not talking about cocaine and crack cocaine. And these are things that we know have been around, and these are the things that we know are driving a lot of the challenges that are facing and that people are facing in their lives and addiction. And that's where we need to change our focus. We need to get people into connected to services so that they can learn how to check their drugs, and so they know how to use naloxone, which rapidly reverses opioid overdose.
So as you said, the Mass and Cass area seems to have improved, but what are some of the public health interventions that were taken in particular to clean up that space?
So we've taken an overarching public health approach. I think that has been in conjunction with public safety. I think an important part of this that I know is not being done in every city is individualized case management. So we have street outreach teams who are out there every single day of the week talking to people, finding out what their needs are, where are they from, do they have shelter, do they have housing, can we refer them somewhere, can we get to know them over time. This, honestly, it's not being done elsewhere, so I really want to commend how we are approaching this. I think the other thing is that we are continuing to invest in our low threshold housing program, which has been very successful. Those people who are in low threshold housing are able to access more medical services. They are able to access treatment. They are able to access ongoing assistance in regards to gaining longer term housing.
So again, taking a wider, more holistic approach to the problem.
Exactly.
All right, you're going to stay with us. Up next, addressing racial inequities when it comes to maternal health, when our conversation with Dr. Bisola Ojikutu continues.